adianta nem me abandonar, porque mistério sempre há de pintar por aí. Pessoas até muito mais vão lhe amar, até muito mais difíceis que eu pra você. Que eu, que dois, que 10 milhões, todos iguais. Até que nem tanto esotérico assim. Se eu sou algo incompreensível, meu Deus, é mais. Mistério sempre há de pintar por aí. Não adianta nem me abandonar, nem ficar tão apaixonada que nada, que não sabe nada, que morre afogada por mim.
Não adianta nem me abandonar, porque mistério sempre há de pintar por aí. Pessoas até muito mais vão lhe amar, até muito mais difíceis que eu pra você. Que eu, que dois, que 10 milhões, todos iguais. Até que nem tanto esotérico assim. Se eu sou algo incompreensível, meu Deus, é mais. Mistério sempre há de pintar por aí.
Hello, good afternoon. Welcome back to this. What's that? Sim. Tá. Eu pago agora. So this afternoon we have the pleasure to have here three people that have been working with depression for a long time. So the idea here is to bring you a sort of an overview from a psychiatrist, from a biologist, and from two biologists, I would say. Here we have Professor Emerson Arcoverde, who's a psychiatrist. He's going to be the first one speaking about depression, clinical aspects of depression in the view of a psychiatrist. And then we'll have Rafael Lima, who is a former PhD and now he's a postdoc in the Institute, who has done a lot of work with psychedelics with 5-MeO-DMT in his master's, and then with NN-DMT for his PhD. So he's going to be speaking about the challenges of doing research in an animal model of depression. And then Professor Nicole Galvão Coelho, who's a longtime collaborator in all the projects that we do with ayahuasca. And she's going to be speaking about the nature of the biological nature of depression, and also the biological nature of the antidepressant effects that some of these treatments give. So I'd like to welcome Professor Emerson to the stage. So each one will have 20 minutes. And then at the end, we'll have 30 minutes for questions. Thank you. Emerson.
Thank you. Good afternoon to all. So I will talk a little about major depression, what is in the current psychiatric treatments. As the definition of depressive disorders, as like we have in the International Classification of Disease, the 11th edition, depressive disorders are characterized by depressive mood or loss of pleasure accompanied by other cognitive, behavioral, or neurodegenerative symptoms that significantly affect the individual's ability to function. A depressive disorder should not be diagnosed in individuals who have ever experienced a manic, mixed, or hypomanic episode, which would indicate the presence of bipolar disorder. We have to go far from the idea that depression, major depression, is sadness. Because I'm sad because I support the ABC soccer club here in Natal, and now it's going to the 3rd division. Who supports Santos Football Club, that's going to the 2nd division now, it's sad. It's not depressive. So I'm not depressed. I'm sad. I support a really bad soccer team. Because major depression, we have one of the symptoms that is sadness. But we have a whole constellation of different symptoms that characterize this disease, this psychiatric disorder, this mental disorder. So being sad is quite different from being depressive, because you have not only the sadness, but the lack of pleasure, I mean, things that you had pleasure before, and the physical symptoms, like the alteration, the sleep disturbance, the appetite disturbance, and the sexual dysfunction, the pain, loss of energy, and this whole thing happening for our right amount of time, at least 2 weeks, and this is could be major depression. You have a secondary depression, like if you have a hypothyroidism, and you can be depressive, but not because of a mental disorder, but because of a disease of the thyroid function. So we have to have not only the sadness, that one of the things that if you're going to do an interview and the people will start to ask, but I'm sad, I'm depressed. No, it's quite different. And that's why these biological strategies to treat depression are so useful. And we have these new strategies like psychedelics or like ketamine. We have a really strong response to the treatment. Like ECT, electroconvulsive therapy, is the most powerful treatment for resistant major depression. And so this warrants that it's a physical illness with a presentation that's behavioral. Like the mood disorders, we have the major depression that is most prevalent, mood disorders among different kind of populations. Bipolar disorder that in fact a big part of resistant depression is in this population that in some aspects are not diagnosed correctly. So if you have a really difficult, hard depression to treat, sometimes this isn't the major depression. It's bipolar depression that tends to be more resistant to treatment and really difficult with hard symptoms, tough symptoms to deal during the day. And people with this kind of depression generally has a really strong depression. Dysthymia and cyclothymia I won't talk a lot about. That are chronic disease, mood disorders that generally aren't so different to treat compared to major in bipolar disorder. From a historical point, since the antique times with Hippocrates, we have his calling, what we call major depression was melancholy. Since more than 15 100 years, 500 years before Christ. Arateus da Cappadocia that recognized the association between melancholy and mania. So this was bipolar disorder. People that has major depression, but depressive episodes with euphoric episodes. But this was long time ago, 500 years before Christ. And this guy was the first to recognize a really common disease nowadays. Anybody knows? Arateus da Cappadocia was the first to describe diabetes. Yes. So psychiatry is culture too. The diabetes was discovered by this same guy, first described. And I think this is only a coincidence. We have a high prevalence of diabetes among our bipolar patients. So I think it was the same patient with bipolar and diabetes. This guy is really famous. Sigmund Freud was a guy that formulated the hypothesis that depression had in common with mourning the response to the loss of the object of desire. But mourning, grief, a healthy response would differ from melancholy due to the intense expression of ambivalence, feelings of hostility previously associated with the object. So he was the first to characterize the difference between among grief and melancholy. And we have this tough fight between Freud and Kraepelin, because this guy, with a lack of hygiene that was Kraepelin, he spent too much time among our patients, was the first to describe in a well-designed way the biological nature and the natural history of most of the more intense and difficult to treat psychiatric disorders. And Freud was the guy that introduced the ambulatory treatment to medicine for mental disorders. We can't let Freud out of the importance that he has nowadays. If we didn't have Freud, we didn't have our treatment, outpatient treatment. He was the guy that introduced this. Before him, was only in hospitals. So he was the guy that said, these people can be treated outside the hospital. And he emphasized that with his work. And with epidemiology, we have almost 10 to 15% of the population will have an episode of major depression, and a depressive episode during his life. It's a high rate, like 1 in 10 people. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Sorry. 1, 2, 3, 4, 5, 6, 7, 8, 9. Sorry. 10. 1, 2. So it's really prevalent. 1 in 10. And from this, 40% will respond to treatment. Yes, for the first treatment. For the second treatment, 30%. The third treatment, after the second failure, 10%. So if I receive a person with resistant depression, that is after the second failure to a well-designed treatment with the psychotherapy and the antidepressant, given for 6 to 8 weeks, and he failed for the second time, we have only 10% of response rate. And this is the population that have resistant depressive disorders. And it's quite high. I'll pass this. 87% of people with major depression have reduced psychosocial and work functionality. We know these numbers, and they are really, really bad. 75 to 90% of people who have multiple episodes, each new episode more easily triggered, episodes become more frequent, severe, and resistant. If there are residual symptoms, recurrence rates are 3 to 6 times higher. So we have not only response, but we have to remit the episodes. It's a chance with family. It's a genetic disorder, and 40% of agreement for higher pressure between twins. The natural history of major depression is variable. The age of onset extends throughout life, but the average age of onset is 4 years. So between the 30 and the 40s is when you have the first episode of major depression. And when we have a really early onset of major depression, probably we have another disease. Probably it's bipolar disorder. So we have all these teenagers and adolescents with really severe episodes, major depression episodes. Probably we have other diseases, not only major depression, but that is more common among the 40s, not the 15, 16 years. No, this isn't expected. Around 30% of patients suffering from depressive episode do not respond to drug treatment. That's 30 to 40%, as I already said. These are the criteria. We have fundamentals criteria like sadness and lack of pleasure. We have to have one of those criteria to go to the other criteria like change in sleep, in appetite, sexual function, energy, and we have to have at least 5 criteria for 2 weeks to characterize depressive episode. These are the DSM-5 criteria. Is the same. I won't talk a lot about this. Some strategies are to try to reach people before they are with severe depression, in the really beginning of the case. So a good strategy is not to rely on psychiatrists only, but in clinicians from the other areas. If you have, for example, the gynecologist looking for depressive patients, this will make it easy to see these people before they are severely depressed, and they are easier to treat. So this is a good strategy to try to respond to this high prevalence of major depression. We have an important differential diagnosis with grief, anxiety disorders. They also called hysteria, that we don't have this criteria anymore. Obsessive compulsive disorder, schizophrenia, schizoaffective disorder, organic syndromes, and use of drugs or medications. Till 1 month after using a substance, you can have some difference, some changes in mood. So you have to have a long period without substance abuse so you can diagnose depressive disorder. And treatment, what we can do? Pharmacological treatment with antidepressants. They're the first choice of treatment. And we have to individualize this kind of treatment. Don't exist the best antidepressant for everybody. No, we have to individualize for each patient. Non-pharmacological treatment, different psychotherapeutic approaches, but the cognitive behavioral therapy is the most used and with more evidence. These are some of the antidepressants that we have. Not one of them are more efficacious than the others, but we have to individualize based on side effects. This is a really important trial, sequenced treatment alternatives to relieve depressions. More than 4,000 patients. And what study did was to try to find what was the best way to treat people that doesn't respond to treatment. And this was the biggest and the more, I think, reliable study of this kind of treatment. Before start D, we have a characterization definition of resistant depression that utilized one failure to antidepressant treatment. If you fail to one antidepressant, you are treated as a resistant depressive people. After start D, what he did, he saw that remission rates were lower than expected for each antidepressant. There is no medication that was clearly superior to another. He switched in an association strategy. There are reasonable options after initial treatment failure. It should take longer to achieve remission, 8 weeks. That's what we consider now, what's the right time. Cognitive therapy is a well-tolerated option for patients failing their first antidepressant. Pharmacological difference did not translate into clinical differences. And there was no significant difference between patients treated in primary care and psychiatric settings. Important predictors of relapse were psychiatric and clinical comorbidities. And the probability of response after 2 well-conducted drug trials decreased substantially, suggesting that a more appropriate definition of refractory or resistant depression should take into account 2 previous antidepressant treatments and not just 1. And this change reduced this trial. Furthermore, these observations point to the need for more decisive approaches in case of refractoriness, which are not limited to just changing the antidepressant regimen, like ECT, MTS, TDS, and others. And now ketamine, DMT, and the others that we are studying nowadays. So resistant depression is this when you fail to 2 different treatments. Despite advancing pharmacological and non-pharmacological treatments for depression, strategies to improve treatment-resistant depression continue to be inadequate, leading to poor outcomes and functional impairment. That's what we see in the clinical practice every day. According to Canadian Network Mood and Anxiety Treatments, the CAMAT guidelines, atypical antipsychotics have been reported as an effective augmentation strategy to antidepressants, aripiprazole, quetiapine, among other agents, mood stabilizers, combination of antidepressants, use of stimulants, steroid hormones, and ketamine have been investigated. With previous methods have shown evidence for use of AS, lithium, and ketamine and sketamine. And this is a new study, augmented strategy for treatment-resistant depression. This network meta-analysis suggests the superiority of regulatory-approved adjunctive atypical antipsychotics, steroid hormones, dopamine compounds, and lithium as strategies. And this is a study with novel and emerging treatments. So here we have ayahuasca, we have ketamine. So ketamine research and ketamine has substantially increased because of interest in novel and rapid action. Ketamines contain 2 enantiomers. As we know, both are glutamatergic agents acting as antagonists of N-methyl-D-aspartate and NMDA receptor in the brain, and acts increasing the conversion of brain-derived neurotrophic factor, BDNF. This is a photo of the first infusion of ketamine that we did almost 6 years ago at our university hospital. This was the anesthesiologist that was with us, but nowadays he said that, no, this is too simple. You can do it alone. So nowadays we only count with the psychiatrists. So we don't have doubts that ketamine is effective. But we have nowadays other options, like dextromethorphan. That nowadays is the only medicine that we have in the market, Brazilian markets, VIII, xarope 44E. So I'm giving cough syrup to my patients with bupropion that was released, approved by the FDA as a treatment for major depressive disorder. So nowadays I'm giving cough syrup with bupropion to treat major depression. And it's good. He blocks NMDA receptors too. And he interacts with bupropion, difficulting the metabolism of the bupropion. So it lasts longer in the organism, and you have the NMDA blocked by the dextromethorphan. And it was approved by the FDA. And is an oral, rapid-acting antidepressant. That's Alveliti, the trademark. But now we don't have the Alveliti here in Brazil, so cough syrup with bupropion. In this meta-analysis, we have this review where we have ketamine and intra-analysis ketamine as category evidence of 1. And we have ayahuasca and psilocybin with 2 level of evidence. But I like this trial, this article, because we have omega-3 fatty acids as level 1. Yes. And I prescribe a lot omega-3 fatty acids. It's cheap. We have in every pharmacy, and it's efficacious as an adjunctive, not as a standalone treatment. But we can add omega-3, and we have a reasonable response. I won't talk a lot about ayahuasca. I'll pass this. Sorry, I don't have time. My colleagues know more about this than me. Foi. Passar. Next. Here. I'll talk a little about Darwin's contribution to psychiatry. He was the first in this publication, The Expression of Emotion in Men and Animals, to talk about the eyebrows are not infrequently oblique, which is due to their inner ends being raised. These products peculiarly form the wrinkles on the forehead, which are different from those of a simple frown. The downturned corners of the mouth, which is so universally recognized as a sign of being out of spirit that is almost proverbial. He was the first to call this melancholic omega. That's the frame that we have here in the forehead when they are when they are depressive. This is the wrinkle that we have here. That's a sign of depression since Darwin. Here's the omega. And with this, another name is very good signs. In 2006, some dermatologists tried Botox toxin to treat major depression, and they succeed. So if you add Botox to the treatment of major depression, you can have an improvement. And this, we can ask, people start to feel pretty, and then go easy with the depressive symptoms. But this isn't true. Some studies try to, nowadays we have more than 5 controlled trials that try to put Botox as an alternative to treatment of major depression. And we have meta-analysis. So nowadays we have, these studies try to associate the previous wrinkling level, negative correlation with improvement in depression level, association of prior wrinkling level with negative correlation with baseline depressive level, association of wrinkle change in change in depression levels were negative too. 5 clinical trials. And we do this in our hospital. This was the first application in 2018. And after that, I start to receive photos of foreheads in my cell phone by the residents And nowadays I'm evaluating for heads. But no, I'm kidding. But this was a photo that a resident sent to me. And, so professor, let's go. Let's try Botox. No, let's try fluoxetine. And after that, we tried Botox. Thanks. That was it.
Thank you. So I'd like to invite Dr. Rafael Lima for his presentation on the challenges of doing research on depression in small animals. Thank you.
So I was, while the presentation, let me see if you can, okay. So I was a student here, as Draulio did say some time ago, and I finished my PhD like some months, and I was working with an animal model of depression, and I did understand some things that I want to bring here for you. And I will not talk about what is depression because Emerson did that so well. And also, I think that the takeaway message that we could understand is that we do not know much about depression, since omega-3 and other treatments just pop out as something that can work, or we are doing the research in some way that we can say what we're trying to say. So, first of all, why use animals to study depression? When you are working in laboratory conditions, you have more control, far more control that you can have in a naturalistic way. So the biggest advantage for working with animals is that we can control things like temperature and humidity, but also we can control the genotype of the animals and social interaction and food and other things that are normally confounding when we're working with humans. And we cannot understand in this scenario that we do not know much about the disease, or at least how it's generated and treated. So know those things and control those things can be very, have a bigger explanatory potential. And also the consistency, since we can repeat and see other people do the same thing in different conditions with different things. And this is like the goal of science. So make something that is so consistent that we can repeat in different places and different settings. And other advantage when working with animals is that we have a wider range of sampling, meaning that we can collect brain tissues and other samples more freely. Like when work with people, like the guys that work in the hospital with humans, you cannot like collect the blood samples, for example, all the time, like at each 5 minutes to build a curve of anything. But with mice, with some technological advance, we can like inject the drug with more precision and collect some samples and other things. So we have this liberty. And as we saw, some of the experiments that have been doing with animals, it's completely impossible to do with humans. Like the things put electrodes in the skull and collect other variables all the time, like 24 hours and other things. So we have more freedom when work with animals, but it's not a lawless situation. You can do anything that you want with them, because we have also ethical constraints when to work with animals, but of course they are more flexible than with work with humans. So even when work with animals, we should be ethical, of course, and we need to replace the models that you are using in order to use different animals for different questions. And like if you need a bigger number of animals, it would make more sense to work with animals that can reproduce very fast, and like flies and other things that you can have a bigger number without less suffering. Also reduce the number of animals through refine experimental conditions and settings and methods. And of course, we can do a lot of experimental things with animals that we can do with humans, even with the consentment. It's not right to do. And also another advantage, it's more for basic science, but still, when you are working with something that we do not understand, it's very beneficial to isolate all the characteristics. So when working with different species, we can answer different questions. For example, can your cat be depressed? Can your dog be depressed? Or things like that seem silly, but can hold a lot of explanatory potential when you look for different biochemical backgrounds and different behaviors and ecological situations, so we can understand different things. And here, I'm just showing that it's from Department of Agriculture in the United States. It's just showing that more of the biggest part of the research there is done in rats and mice, of course, but also fishes, birds, and some invertebrates. And just a small fraction is done in different kinds of animals, like non-human primates and rabbits and other species. Just showing that there is a lot of animals that are not there to be understood. And so basically the advantages are we have more control, we can go deeper, and we have more freedom when we work with animals. But we also have some limitations. And when we're modeling depression, specifically, the biggest problem comes that we can access the subjective of the animal. So we cannot know if the animal is sad or feel guilty or have suicidal thoughts. So this is the kind of research that you can do with animals. Also, another thing is the heterogeneity of the disease. So we do not know exactly what are the susceptibility, how people gonna be more susceptible to develop depression, in which situation and everything. So since we do not know that for what we're trying to model, we can model, right? And so it's impossible to assess subjective. I think this is the biggest problem. And also the diatheses make things complicated, but also it's where the model can shine because it can show some understanding about the process. And the heterogeneity of human depression, what exactly is, and the types and other things, it also poses a challenge to the research with animals. But also the research at all, I think that the whole science has a problem with reproducibility and reliability. So people just pop out different methods. So how can I compare a thing that is essentially different of other things? So it would make the standardization would make things easier, but it's not the whole scenario. So here is just some aspects of the depression that needs to be addressed by in humans. And of course, some of them we can control in animals, but we can also like simulate them for them. Like anxiety disorder, of course, they come together. We can simulate them in animals, but interpersonal problems, family problems, and those things, of course, we can't. And now I talk about advantages and limitations. So let's talk about what makes a model good. It's the validity. Basically, when working with those models, you need like to fulfill three basic criteria. It is the first, the face validity, meaning that does the phenotype, like the animal in the end of the process, looks like the depression in people. This is the face validity, and also the constructive validity or etiological validity, which is the process in which the animal reached there. It's somewhat similar to what we see in humans, but also it has some problem because it does not know exactly what is the process. And the third is the predictive validity. Those classical treatments share efficacy, and there's a lot of critics about. This is just one idea that is being discussed, like in the literature, and there is other types of validity being like developed, and people questioning about what we should do to understand better. And people are promoting suggesting different types of validity, like homological validity, pathogenic validity, convergent validity, and the list just goes on. And some critics about how we should say if the model works or not, and I want to like bring here, and then maybe we can discuss later. It's some idea that popped out some time ago. There is the research domain criteria from the NIH, which basically put the research in some small boxes, like we should look for the symptoms and treat the symptoms and not exactly look for the disease as it is. Of course, it can have some downsides, but also had some advantages in it, and just want to bring here and maybe discuss later. Also, if you need the predictive validity as criteria to validate the model, what we're going to do with treatment-resistant depression. So we're never going to have a model for that because you can treat it. And also, another critique is why we showed, like, in this predictability, people say a lot about selective serotonin reuptake inhibitors as a gold standard. And as Emerson shows, the efficacy is very low. It's like 40%. Why it should be the gold standard? Why 40% should be the barrier that we have? Well, so just wrapping things up, let's see what I try to say here in details. Just you need to, when working with an animal model of depression, you need to choose and apply the model in a more planned way, like with all the whole steps. The next steps will be the verification of the depression-like phenotype, because not all the models are perfect. Then you need to put a midpoint analysis to see if they have depression or not. And then you put the experimental treatment that you are trying to use aside with a tested antidepressant as a positive control. So you're gonna have the predictive validity there. And in the end, you use the sampling that is appropriate for the character of interest, meaning that you need to choose the model thinking about what you're gonna sample, because some models just replicate some aspects of the disease, so it makes no sense to try them like for some models do not work like for social aversion or anhedonia or apathia or everything. So you need to know what you want to see in the end at the moment that you choose the model. And here are just some examples that models that are being most used in science. They are based in early life stress. The categorization is different where you look at, but I just choose one here. But it's early life stress, and there is some models that have adulthood stress. Of course, they are different in the etiology, like to reproduce different characteristics. Like, for example, maternal separation, it's somewhat of postpartum depression, and it has some features that can be looking there. And also some lesion models are specific for the animals, like olfactory bulbectomy. It's the removal of the whole olfactory bulb. And some pharmacological models, like reserpine and corticosterone, also polysaccharide injections. And some genetic models that are more complex because of the genetic background and everything that we can see in the human population that can lead us to something, and then we put in the animals to understand it better. And basically, the early life stress, like maternal separation, as I said, it's a good model for postpartum depression, and also it's for mothering. It's just the animals go through small sessions of stress, like very early in life, and some models that have a biological causation. Also, the adult stress, this UCMS, it's the model that I used in my study. It's the unpredictable chronic mild stress. It's a very long one, and it's done in the adult phase of the life. I mean, long in the onset of the symptoms. And also learned helplessness. It's just in some more modern models like the optogenetic manipulation, it's something that are just popping out lately. Some genetic models which are very restricted. And also the sample that should be done for different characteristics, like for anxiety, there is some appropriate tests to do it, and of course some models are better for it. For anhedonia and apathy and despair, our characteristics that are common for depression that you can measure in animals, so it's good to link the model to the sampling. And so to finish, models are limited. Of course, they are models. Models are linked to sampling. The advantage and the weakness of animal models come from standardization. So if it's the very old joke, like things work with if they are perfectly spherical in the vacuum, but well, we need to start somewhere, right? And preclinical and clinical research are complementary, and each one holds different explanatory potentials. They should exchange hypotheses, like if you have some hints from the clinical research and you can test them in humans, go for the animals and go like back and forth to see if you can get a better understanding of it. And that's pretty much it.
Thank you, Rafael. So we'll have time for questions at the end. I'd like to invite Professor Nicole Galvão Coelho. So she's a professor at the Physiology Department here at the Center for Biosciences. And she has been working with us since I arrived here in 2009, so a great partner. Thank you very much, Nicole, for accepting the invitation and being here almost in every month basis. This is like the third seminar that you give to us this year, I guess. Thank you.
Good afternoon. Thank you, Draulio, for this invitation. Thank you, everyone, for being here. Thank you for you that is watching through YouTube. Oh, sorry, my. Okay. So, what is it? This is what we most desire today. What we are looking for: peace, love, mental health. But actually, this is what we have. Our world is facing an epidemic of mental disorders. The incidence of mental disorders have been increasing a lot, rising very fast, mainly depression, anxiety. And psychiatry has some challenges that I would like to talk to you today. First, I'd like to talk about the symptoms overlapping. As you can see here, depressive symptoms is part of several mental disorders like unipolar depression, bipolar depression, post-traumatic stress disorders, schizophrenia. It's turned difficult to do diagnose, not every time, but in some situations it's difficult to do a diagnosis with these symptoms overlapping. Moreover, there is a high heterogeneity in a single diagnosis. For instance, two people could get the same diagnosis without sharing any common symptom, while about 270 million different combinations of symptoms is possible to have for a diagnosis of PSTD or major depression. So, as you can see here, we can have a lot of misdiagnoses, a delay in getting the right treatment to the right patients, and it turns high individual, social, and economic costs. And what is the solution? Actually, I don't have the solution. No one has the solution. But we are looking for the solution. And there is a new field in psychiatry that we call precision psychiatry that have been investigated biomarkers. Different type of biomarkers like electrophysiological data, image data, molecules. These biomarkers are used to assist, diagnose, and to predict treatments. We use this biomarker to build models, math models, to help and diagnose or in the treatments. But current, these models are made in most part with a single biomarkers, which results in models very weak that is not used in clinical practice. The new idea in this field is try to investigate more biomarkers and build panels of biomarkers to have strong models and be used in clinical practice. Another challenge in psychiatry, as Emerson said here, it's about treatment resistance. Between 20 and 60% of patients have treatment resistance. For depression, we have about 30% of patients with treatment resistance. And what is treatment resistance? As Emerson said here, is the fail in 2 or 3 right treatments. So despite this huge number of patients with treatment resistance, and in the last year, you can see here in this graph an increase in the studies in the fields about treatment resistance. In some, less than 1% of all studies in psychiatry investigate treatment resistance. So it is still an under-investigated disease. And what is the solution? Again, we don't have, but we are looking for. So the idea is have more studies about new treatments, as Emerson said here, someone, like complementary therapies, physical exercise, body-mind therapies, psychotherapies, or alternative treatments, like the classic psychedelics, such as DMT, psilocybin, LSD, or no classic psychedelics like ketamine and MDMA. And how we are trying to help in this challenge. So our group here in this university have been doing several studies with major depression, different types of treatments, as Emerson said, since Botox till psychedelics. We have studies with physical exercise, body-mind therapies, ayahuasca, DMT, ketamine, Botox. And in all these studies, despite we are investigating the clinical response, we are also investigate biological response to help in the precision psychiatry. Oops. So, across the several studies, that we are doing here, I'd like to talk today about ayahuasca, depressant, and biological response. Ayahuasca is a psychedelic brew from Amazon rainforest and is used for many, many years by indigenous people and more recently by syncretic church in the ritual and for healing. Where did it come from the idea of studying ayahuasca for depression? First, we must understand a little bit about pharmacology. Ayahuasca is a brew made from two components, main. There are others, but the main components of ayahuasca are a leaf that we call chacruna. In this leaf, we have a molecule named DMT. DMT induces the psychedelic effects, but is an agonist of serotonergic receptor type 2A. The other components are wine that we call mariri. Mariri has 3 beta-carbolines, and these beta-carbolines are inhibitors of MIO, so they have the same action of some antidepressant. Besides the good evidence about ayahuasca pharmacology, many observational studies have been showing that people from church, they used to say that they have good mental health. In this study, it was a large survey that was done in collaboration by a group in Australia and our group. It was 2 years ago, like 2 years ago, I believe, yeah. And we had almost 2,000 responders. Part of these responders said that they had depressive symptoms, and after ayahuasca intake, they said that the depressive symptoms were completely or much improved. With this good evidence, we decided to study ayahuasca in preclinical and clinical studies, but today I will focus in clinical studies. The first study was done in São Paulo University. I was not part of the group at that time, I was very young, but Braulio was part. It was an open-label trial with 17 treatment-resistant patients with depression, major depression. And after one dose session with ayahuasca, the levels of depressive symptoms here in red, the red line, start to drop very fast, some minutes after the intake till 21 days. With this interesting result, Braulio decided to come to Natal and coordinate a more complex study where I was invited in that time to be part of the group. It was a placebo-controlled trial, and it was a very important study because it was the first control trial that tested a classic psychedelic in depressive patients in whole world. So in this study, we had two groups, one group of depressive patients and another of health control. The health control group was important to compare the biological response. Half of patients, 14 patients got ayahuasca, while 15 got placebo. Controls, 23 got ayahuasca, and 23 got placebo. Our patients had moderate to severe depression, about 11 years of disease. They had tried about 4 different types of treatments before the study with no success. And they were naive or psychedelic. It was very important to help in the blindness of the study. And they were in watch out. I mean, they were not using antidepressants. That was important to avoid pharmacological interaction between ayahuasca and some type of drugs. We used ayahuasca as a brew, and we made a placebo, very interesting. That placebo had similar taste, color, and also could induce nausea, diarrhea, and vomit like ayahuasca does. Here we have our study design. As I said to you, we had just one dose session. The volunteer got ayahuasca or placebo. The dose session had about 6 hours of duration. Here you can see the room where the study was done inside the university hospital. During the dose session, we got several biological measures. As you can see here, ECG, AEG, we collected saliva, formation cortisol, and we assessed several psychometric scales. 2 days before and 2 days after dosing, we also assessed different psychometric scale, and we did fMRI, polysomnography. We collected blood and saliva. Here we have the main study result, the clinical response. It was a PhD fellow, Fernanda, that was supervised by Braulio. We measured depression through 2 scale, Montgomery and Hamilton. Ayahuasca is in red and placebo is in blue. As you can see here, 1, 2, and 7 days after dosing, ayahuasca induced a larger drop than placebo in reduction of depressive symptoms. Regarding clinical response, with 7 days, we saw a difference between ayahuasca and placebo. Ayahuasca induced 64% of clinical response, while placebo showed 27%. For remission, we saw 36% of remission in ayahuasca group, while placebo group had 7%. So the better result was with 7 days about clinical response and remission. We have here a very interesting result. We found that the psychedelic perception was correlated with clinical response. The larger the psychedelic perception, the greater the clinical response. Despite we had a great result, 36% of remission with 7 days, you can see that it's not whole patients that respond to this treatment. And it's usual for different types of treatment. You can have a pain kill, and don't respond to treatment. So, and why? Why some patients respond and others don't respond? So, this is the reason that we are looking for biology too, not just for symptoms, but to also investigate the biology in our studies. As I showed to you, we analyze different types of biomarkers, imaging, electrophysiological data, but I will just discuss with you about molecular biomarker because my main study field. I would like to talk about stress system first. Stress system, the main biomarkers of stress system is cortisol. And in depression, some patients have high cortisol, while other patients have low cortisol. It's not good to have high or low. We should have good levels of cortisol. In our study, we analyzed cortisol from blood, As you can see here, our patient had low levels of cortisol comparing with control, and we also analyzed cortisol from saliva. Here, we analyzed the awakening cortisol response. We collected saliva at awakening, 30 and 40 minutes after awakening. This is a very strong biomarker of mental health. And we saw that our patient had low response comparing with control group. After ayahuasca, 48 hours, 2 days after ayahuasca, we saw that patients that got ayahuasca, actually 3 days after treatment, patients that got ayahuasca start to show the same awakening response of control groups, while patients that got placebo continues to show low response comparing with control groups. So it's like ayahuasca regulated the stress system 2 days after treatment. Another field of investigation is about neuroplasticity. We can analyze neuroplasticity from blood in a molecule that we call BDNF. In depression, there is a notion that patients have impaired neuroplasticity, and the antidepressant response is correlated with improvement in neuroplasticity. Before treatment, we didn't see difference between patients and the control, but after treatment, we saw that volunteers in general, patients and controls had large levels of BDNF comparing with volunteers that got placebo. So ayahuasca induced an increase in BDNF levels. Another interesting result was this correlation. We found that after treatment, patients that had bigger levels of BDNF also had larger improvement in depressive symptoms. Regarding inflammation, part of depressive patients also have a systemic inflammation. It's a low grade, but it's very bad for health. And mainly in patients with treatment resistance shows this inflammation, this systemic inflammation. We found that our patient had the systemic inflammation. They had large level of CRP than control group. After ayahuasca read again, the levels of CRP drops, while after placebo we didn't see any change. So ayahuasca had an anti-inflammatory response. Again, we found interesting correlation between bigger anti-inflammatory response and low levels of depressive symptoms after treatment, 2 days after treatments. In this study, the idea was to understand what during the dose session was important to biological response. Because as I said to you, during the dose session, the intensity of psychedelic perception was related to improvement in depressive symptoms, was correlated with clinical response. So, and for biological response, what is important? And we found that during the dose session, during 6 hours of the dose session, the drop in depressive symptoms was important to regulate the stress system 2 days after treatment. While a low activation of the stress system during the dose session was important to improve neuroplasticity, that was important to improve clinical response. Here we have some results about the prediction of a clinical response. We analyzed if our biomarkers like cortisol, BDNF, and some inflammatory biomarkers predict clinical response. We didn't find any positive, any significant response, maybe because we were looking for models using biomarkers isolated. And as I start the talk, it's not the better way to try to understand clinical response and predict clinical response. Maybe we must to analyze these biomarkers together and try to understand as a panel of biomarkers, but we have few patients to do it, so it's not possible now to do it. As summary, about stress system, ayahuasca regulates the stress system, 48 hours of treatment. Fast drop in depressive symptoms during the dose session was important to regulate the stress system. About neuroplasticity, ayahuasca stimulates neuroplasticity. We found an increase in BDNF. After ayahuasca, high levels of BDNF was related to a better clinical response. Lower increase in cortisol during dose session, as I said, low activation of stress system, moderate larger level of BDNF, and also a better clinical response. Regarding inflammation, ayahuasca decreased systemic inflammation and large reduction in inflammations were related to lower depressive symptoms. And about future, so the idea is keeping studies, looking for new treatments, and in our study we also analyze biological response because we understand that it is important to help and understand better the treatments and maybe improve those treatments. So I will leave you with some thoughts of our patients during ayahuasca ingestion, and thank you.
So I'd like to invite our panelists to start this round of questions. We have about 20 minutes, so please. Questions?
Thank you for your talk. The three of them were very interesting. So I actually have a question for Nicole. It's very interesting. So this thing of the inflammatory component of the depression is a hot topic now, right? And I was wondering, so you have the MRI, right, for these patients. Have you checked if you have also an inflammatory morphological evidence for the brains of these patients?
So I will leave this answer with Braulio. That's the guy of imaging. Actually, we didn't see. I don't know if you have the possible to analyze it through image.
Not the images that we acquired. So they're not sensitive to inflammation, to the level of inflammation that these patients eventually present. So it's not something that we would see in the MRI. So it's not the type of inflammation that we would see in. Not only the resolution, but the inflammatory process is a very
it's a very weak.
Exactly.
Actually, to dosage molecules, inflammatory biomarkers, it's difficult too in the case of these patients because the inflammatory response is not too high like a response to an infection. It's a low grade. Yeah, so I believe that's not possible with the data that we have.
Hello, thank you for the presentations. The question is between Professor Emerson and Professor Nicole. It's because you bring the situation that mostly the patients with difficult depression, they could be bipolar. They could have bipolar disorders. And my question is, what could be the risk to give psychedelics for these patients and bring them to manic episodes? So it's around this.
Thanks for the question. We have a risk because any antidepressant that we give to a bipolar patient, we have the risk. But we have to understand that not this substance have different mechanisms of action. So we can have surprise that we don't have all these risks. As even Braulio sent me a paper today of the effects of psilocybin single dose on bipolar depression in patients free of medicines. We can't treat bipolar patients without mood stabilizers nowadays. So I think it's an open avenue for studies, and in clinical practice we can't say that this is safe, isn't safe. But with mood stabilizers, we can promote, I think, or engage in some studies in bipolar depression. But I will go easier with this thing of free of medicines, and we put on lithium and give this psilocybin or the DMT, what we have to treat resistant depression, but in resistant bipolar depression. So I think with mood stabilizer we can have a safe environment for doing this.
You want to complete, or only if you want? Feel free.
Yeah, I think Emerson said all about it. Just to make clear that today here in University Hospital, there is a service there for bipolar patients with ketamine. That's very safe. Yeah, you can confirm. Yeah. But for classic psychedelics, the first study investigate bipolar patients was released now with psilocybin. So it's a new area. We need to study a little bit more, but I believe that there is a promise in this field.
Yeah, just to complete, up to now, including our studies, bipolar patients are in the exclusion criteria. Bipolar patients and patients with a risk of schizophrenia, family history of schizophrenia. So any risk of a psychotic outbreak, that's the main risk that people are trying to avoid. But like they said 2 days ago, we had the first paper that published positive results in depression in bipolar. So as Emerson said, there's a new avenue that's opening up.
Just one more observation, because I just remember. Despite there is this service in the hospital to bipolar patients, ketamine was not approved for bipolar depression. Okay, it was approved just for major depression, but in clinical practice, yeah, I believe it.
Not approved, but off-label, we give a lot of ketamine to our patients, and it's really good for bipolar depression. And even in CAMET, it's one of the most popular guidelines to treat bipolar. Ketamine is a third-line treatment for for bipolar depression. So off-label, we use it, but with mood stabilizers. I have to repeat this. With mood stabilizer, we can have a safer environment to do this.
Good afternoon. I wanted to ask, I understand these are really new research that is being made now, but I wanted to question regarding after the 7 days after the ayahuasca, would you have any follow-up that you've been doing with these patients? How is this response being?
Yes, we had some patients drop out, so we didn't do a statistical analysis. We saw that the response is still low, but yeah, some patients drop out. I believe Fernanda can answer this question about how many patients drop out.
We have a lot of dropouts.
Yeah.
Like we had 14 in a group and 15 in another, and some months we have only 2 or 3 patients. So that's why we did not have any statistic about that. Yeah.
We didn't go into the details of the open label trial. So we did 2 open label trials with 17 patients. And for these patients, we were able to monitor them for 21 days. This one, we were not able to monitor for 21 days because it was a placebo-controlled. And in a placebo-controlled, once you give a placebo to a patient, you need to guarantee that right away he's going to be back to the treatment. So for the open label, the patient stayed in the hospital for 21 days, and we did observe an antidepressant effect that was rapid, so 1 day after the session, and it remained significant for 21 days. In this one, we were not able to investigate because 7 days after the intervention, we needed to have the patients under a new treatment scheme.
Good, Draulio. Actually, I brought the graph in my talk about this study that Draulio said.
Okay. I have a question maybe more to Dr. Emerson about the hereditary component of the depression. So do you observe in the clinical practice, or do you use this actually, that if you started with one antidepressant, one type of antidepressant, and this was effective in one member of a family, maybe you get another member of the family, you would start with the same one? So do you observe this, that you have hereditary component, which also is affected by the treatment?
Yes, we have a hereditary for the incidence of major depression and bipolar. It's about 40%.
No, I know. The question was about the treatment. If you
and
use
about
this.
the treatment as well.
Yeah.
If you have a brother, a
which
mother,
responded to this one, you would
we
use
try the same one.
Okay.
And we have that this is a good clinical practice and a clue that he will respond to. Because we take out one of the variables that is the biological compound that's quite similar. So it's one of the variables that we take out with this strategy.
Okay. Another simple question. So a lot of these neuropsychiatric disorders, from what I know, they are usually a potpourri of different things which have a common end. And so the common end could be the depression, but maybe it's different things. Is this used in choosing the treatments? So you have subclasses in the major depression which you can identify?
Yes, but this is part of the complexity of this disease. Yeah. We try with the medications, the antidepressants, and with our diagnosed categories to try to make it more easy and clean to do this diagnosis and to point to the right treatment. But what we see with this 30% of response is that we lack some guidance to where to look. And we look at some part of the picture, but we're losing part of this. So this is the difficult with this thing. We have just a part of the whole picture that is major depression.
So you're mixing up a lot of things still.
Yes.
Yeah.
Hello. Hi, so congratulations to everyone about the presentation. It was very good. I will ask to Rafael. So Rafael, you talk about bulbectomized animals models, and I'm particularly interested about it because I study respiratory coupled oscillations, neural oscillations, and I wanted to know if you know if this still being used, this model, and if you know something about the mechanism.
Which model, sorry?
Bulbectomization, I think.
Yeah, there are some publications around, but ablation studies are very limited and what they can. But at least for rodents, it seems consistent and has some. I think that the main advantage, as I say, the model are linked to the sampling. It's about the anhedonia and social interactions. The animal are very disturbed in this section. So. If you want to look those process, it's a good model in animals. It's very consistent. For example, a big flaw of many models is that you do not have 100% of the animals in the end when you apply. But bulbectomy, you're gonna have. So it's the advantage of the model.
Hi, thanks for the talk. I actually have a question about the clinics. So a recent study in England, I think, suggests that the children from the 90s have shorter and the episodes of depression last longer compared to children of 2000 on. I wonder, do you see something similar in the clinics? Meaning, are you seeing younger and younger patients with longer lasting depression episodes?
In the clinical practice, what we are experiencing is a quite different picture that I painted here, that major depression is a scenario, a disease that we see after the 40s, after the 30s. Nowadays, we have a lot of younger people with major depressions and not on bipolar depression. So something's going wrong, I think, because this wasn't expected some years ago to see this higher prevalence of depressive episodes in such young kids and teenagers. So something's not right, but we didn't recognize what's happening until now. But isn't what was expected a time ago. The prevalence is really high, higher than what we expected.
So I actually have a question for the three of you. So there is this thing that the psychedelics work much faster than the classic antidepressants, right? So my question for Rafael is there a cellular molecular mechanism for that? And for you too is, do you think that the experience of the psychedelics is important or only the pharmacology?
Let me start. So this question, it's the big question that I tried to answer with my PhD. It's basically there I did an experiment, used that model, and we tried to see if the trip can influence the results. Like if we remove the trip, we tried with inhalatory anesthesia with isoflurane, and what I saw in my experiment, I actually bring the data, but at the time it's very limited. So, but what I saw there is that we, in the anesthetized animal, we still have some improvement in the condition as sampled. I sampled anhedonia, apathia, and some cognitive aspects. And also we did like cell counting because we were doing neurogenesis and other things. So they also improved there, but the improvement is smaller than the animals that could full experience the trip, like the DMT without the anesthesia. And neurogenesis was also higher for them. But they receive a boost and was higher than fluoxetine, like the positive control, but it was not higher as the DMT alone. And another finding that could be interesting is that I had a group that I applied the DMT in the middle of the protocol that takes like 2 months. And those animals just went crazy. Like they did not improve, but they did not like go so bad as the animals that were depressed without treatment. I would say that something was really unexpected, and we didn't have the tools in that design. I didn't have the tools in that design to see what happened to those animals.
I'll start and then Nicholas conclude. The experience always matters. So when you go to a doctor and you are confident with that treatment, that will have a reinforced effect. And with psychedelics, we have a really strong experience that is unique. And I think that the pharmacological point is really different and interesting, thinking that it's part of the difference, but the experience is another part. So I think this a conjunction. It's these two things, and try to explain these different results.
So regarding molecular levels, as you asked, we believe that the fast response is correlated with the increase of BDNF. The psychedelics increase BDNF faster than commercial antidepressant that leads about 2-3 weeks. I believe it's not whole, but it's a begin. It's understand about neuroplasticity and how fast the substance improve neuroplasticity. And about psychedelic perception, it's still in debate. Actually have new molecules that are start to be studied. They don't have psychedelic effects and still being called like psychedelics. I don't know, we can discuss it later. But I believe that psychedelic perception is very important. As I showed to you here in my talk, we had strong correlation between the level of psychedelic perception and clinical response. And also in our study with ketamine, the dissociation state was important to clinical improvement. So I believe that to humor disorder, psychedelic perception is important. And I believe that psychological support is important too to help understand the psychedelic perceptions and dissociation. But maybe for other type of disease, like inflammatory disease, maybe it's not important, the psychedelic perception.
Just a comment, Dudu. It was very frequent in the trial, people saying that they felt as if they did 4 years of psychotherapy in those 4 hours that I'm here. So just from this, it's very clear that the experience matters. How much, it's a matter of study, but it matters.
Just to add, I think like in my master, I did an experiment with the animals received 5 ml DMT anesthetizing the brain, and we were looking for electrophysiological properties and other things like in the newborn neurons, the young neurons. And what we saw there is that the neurons that took like some time to mature, it's 28 days, something like that. And in the animals that received DMT, they like maturate faster. So in this time window that we give it to both, like the neurons were more eager to integrate in the circuits, and this can be like the fast acting mechanism, like with a single dose. So somewhat it's so strong insult, and the animals were anesthetized that, so the trip was somewhat removed. Also, it's not the goal of the study, but well. And so maybe as Gerardo said, I think that what I learned with that is that the trip can like improve. You can have some guidance and something with that, and but still, even without it, it has something there that you can see. Like it's not all subjective.
Hi, I have a question for Nicole. I am from nurse department, and I think this question is very important. I want to know if people using ayahuasca can eat food with amina, or there are any side effects.
Actually, there is a diet restriction, mainly in religion. We ask to like do a restriction with cheese. What more? It's a so long time ago. Yeah, yes, exactly. There is cheese. What more? A milk. Yes, we asked to avoid, and people in religion context also asked to avoid.
All right, I think our time's up. We now have time for the poster sessions and a coffee break, and we'll gather back at 4.
Não adianta nem me abandonar, nem ficar tão apaixonada que não sabe nada, que morre afogada por mim. Não adianta nem me abandonar, nem ficar tão apaixonada que não sabe nada, que morre afogada por mim.
Everything is fine? Yeah.
Você é assim, um sonho pra mim. Te vejo, penso em você, desde o amanhecer até quando me deito.
Eu cheguei vestido de rei, quem me chamou?
Eu cheguei quem me chamou.
Eu cheguei vestido de rei Mutalambô.
Eu cheguei vestido de rei Mutalambô.
Eu cheguei vestido de rei, quem me chamou?
Hello.
Eu cheguei vestido de rei Mutalambô.
Anyone from the organizing committee in the room? Alguém da comunidade da organização? Não?
Eu vi que ela andou. Eu vi que a mata rompeu. Eu vi que a flecha correu. Eu vi que a porta bateu. Chegou meu pai caçador. Eu cheguei vestido de rei, quem me chamou?
Eu cheguei vestido de rei, quem me chamou?
Eu cheguei vestido de rei Mutalambô. Do matagal é o guardião do embornal, é o chefe da guarnição. Ele é da casa real, ele é quem briga com o mal, ele é o meu capitão. Eu cheguei vestido de rei, quem me chamou?
So, good afternoon, everyone. We are just starting the last session of the House Symposium, and it's a great pleasure for me to introduce Dr. Monique Sclapes. We have been collaborating since 2019, I think. So 5 years is already a lot, but between it was a pandemic, so we have to stop some traveling, some work. Dr. Sclapes has completed her PhD in neuroscience at Pierre-Marie Curie University in Paris in 1990. Sorry, I have some dates here. So
Yeah, I apologize. So I will skip that. So she did some postdoc in the US, and then she got a permanent research position at INSERM in 1998. Also, I did again. And then research director at INSERM in 2016. Nowadays, she leads a group, a research group, aiming to understanding the GABA function in neural networks and epilepsy. So it's a very affinity with our group here in the Brain Institute. At the Institut de Neurosciences des Systèmes in Marseille, and she's funded by INSERM. Her work focuses on the network, a very important and new projection that she discovered between the SAM and the dentate gyrus, where she described the neurochemical nature of this projection and how this projection into the inner molecular layer of the dentate, of the granular of the dentate gyrus works in pathological condition, mainly in epilepsy. So Monique, thank you very much for preparing this talk for us. The stage is yours. Thank you very much.
Thank you, Claudio. It's a pleasure to be back in Natal. It's my second time in Brazil and in Natal, and I really enjoy it. I thank, of course, Claudio, but also all the organizing committees that invite me to present our data on this very nice house symposium. And really I enjoy to discover your new institute. When I came in 2019 for the first time, you were in this, most of the people were in this little house, and really now you have a wonderful institute, and you should enjoy it and really do your best for create a dynamic, scientific dynamic in this institute and your country, such a nice country. So now, today I really would like to present some new data that are not published and that concern a structure of the hypothalamus that we discover could contribute to an epileptogenic network in the epileptogenic network in temporal lobe epilepsy. So, for more than 25 years, my research has been triggered by a main question that how can we understand how a normal brain or a region of a normal brain become epileptic, that is to say, able to generate recurrent spontaneous seizures. And I have been addressing with my colleague in Marseille, and in all around the world, I have been addressing this question mainly in mesial temporal lobe epilepsy that are limbic epilepsy. Why? Why in mesial temporal lobe epilepsy? This epilepsy are among the most common form of drug-resistant epilepsy, partial epilepsy, in adult and childhood. And they are characterized by, like all epilepsy, by spontaneous recurrent seizures. But in this mesial temporal lobe epilepsy, these recurrent seizures are associated with an excessive and hypersynchronous discharge of neuronal population that are generated in a multistructural region of the temporal lobe including the hippocampal formation, the amygdala, and the entorhinal cortex. And as it's illustrated here, you see this excessive and hypersynchronous discharge of neuron in the hippocampal region of this patient, the amygdala, and the entorhinal cortex. And we know that in this type of epilepsy, the seizures are really susceptible to stress and some vigilant state. And the patient, most of the time when you look at the hippocampus of this patient, they display an hippocampal sclerosis. I think that, yeah, it's not. That you can observe when you do the histology on the hippocampus, that it's the tissue is basically obtained after surgery of this patient that are mainly going for surgery because those kind of epilepsy are really drug resistant. So the only alternative for when possible is surgery. And when you look at the hippocampus of this patient, you see this huge neuronal damage and cell loss in the hippocampus, in the hilus of the, or the plexiform layer that we call in the human or primate. You see this huge cell loss as compared to the hippocampus of patient, it's not a patient, it's on tissue from a human that we obtain after post-mortem. So you compare and you see this huge neuronal loss in the hilus, in CA1 and in CA2. The cells are mainly preserved as the dentate granule cells, but you see a huge dispersion of the dentate granule cells. So one of the main hypotheses that, I'm sorry, what have you? It's this one, the following one, so, okay, go ahead. Sorry. One of, in this epilepsy, sorry, it is well known that most of this epilepsy, the patient have an history of a cerebral insult that occur. Cerebral insult could be a trauma, infection, febrile seizures that occur in adult but also early childhood. And after a certain time that in human can take 10 years, you see the emergence of the first spontaneous seizures. So if you want to understand how a neuronal network becomes epileptogenic, you have not only to understand the organization of and the properties, the morpho-functional properties that characterize the structure, the neuronal network of the limbic system, but also you have to understand the dynamic of this reorganization that occur between the cerebral insult until the emergence of the first seizures. So obviously we cannot address this question in human. We need to work on animals models, and the animals model that we have been using for a long time now, it's a model that we induce by triggering a status epilepticus in these animals, in the rat or mice, you will see. And this status epilepticus, that it's defined as a long and sustained seizures that can mainly last for 1 hour. we can induce this status epilepticus with a drug like pilocarpine, that it's mainly a cholinergic agonist, but other drugs like chylate. The important heavens is the status epilepticus. Without this status epilepticus, the animals will not develop spontaneous recurrent seizures, will not become epileptic. So basically, we have been looking the development and the reorganization of the limbic structure that occur between the status epilepticus during the latent period and the chronic stage, in order to determine what has the minimum, if I can say, morphofunctional reorganization of the limbic system that is necessary to induce seizures. And okay, no, previous one. Okay, so when I start these studies, the main hypothesis was that these seizures, the spontaneous seizures, was due to an hyperexcitability of the hippocampal principal neurons. So this hyperexcitability could be resulting from a decrease of inhibition, an increase of excitation, of a modification of the membrane properties of these neurons. So for more than 20 years, we have been dissecting basically the different subpopulation of GABAergic neurons and glutamatergic neurons, principal cells, including the pyramidal cells and the dentate granule cells, and the huge amount of the different population of GABAergic neurons, in order to understand how, with development of the epilepsy, this network was remodeling. So I will give you quickly the main results. All the data has been published. Okay, Claudia. Okay, when you look at the, actually, the histology of this epileptic animals, just after the status epilepticus or before the emergence of the first seizures, what you can see, it's a cell loss that it's mainly located in the dentate, in the hilus of the dentate gyrus. These are the epileptic, the pilocarpine animals. You see the cell loss as compared to control. And we see also a cell loss in the stratum oriens. But clearly in these animals, as compared to what I've been showing in the epileptic patient, we do not see, we see a very well-preserved pyramidal cells layer and dentate granule cells layer. So it doesn't look like it's necessary to lose those neurons to generate seizures. And actually, if you wait for 2 or 3 months for these animals to experience chronic seizures, you will finally see a cell loss in the CA1, in the CA1 and CA3 pyramidal cells that mainly will result from the animals' experiences many seizures. So what are the populations that degenerate actually? You see that it's a discrete population of neurons in the hilus and stratum oriens. So I'm going to go quickly, but basically among the many GABAergic neurons that has been described even in the hippocampus, we have more than 21 different types of GABAergic neurons. We demonstrate that among these different types, there is only 2 GABAergic cell types that degenerate. These cells that have a soma in the stratum oriens and dendrites, and that innervate the apical dendrites, basically, of pyramidal cells. And this population that innervates specifically the initial segment of the pyramidal cells. So, and here I illustrate these two cell types that degenerate, and this is the only cell type that degenerate. And we have this counterpart also in the hilus of the dentate gyrus, a similar population. One type of neurons that we call stratum oriens center neurons, and it's responsible for inhibiting the distal dendrite of pyramidal cells and modulating the entrance of the information coming from the entorhinal cortex in the hippocampus. So the next one. We show that these cell loss occur very early after the status epilepticus. But as I just say, we have only two cell types that degenerate. What happened to all the other population of GABAergic neurons? So to answer to this question, we did some hippocampal slices on these animals at a different time of the development of the epilepsy, and we patch these neurons that was this resistant GABAergic neurons in this tissue, like this one, fill it in order to basically identify the cell types and record from these neurons. And when you are doing that, for many resistance GABA neurons in this tissue, what we clearly see that all these resistant GABAergic neurons start to be or are hyper-excitable. So do we have a decrease of GABAergic inhibition? Of course, we have a cell loss of a subpopulation of GABA neurons, but all the others GABAergic neurons look like they attempt to compensate the loss of inhibition due to GABA, to the loss of OLM cells, for example. So, next one. This is what happened to the glutamatergic network in these epileptic animals. So we show, and others show, that at least you have a structural plasticity, that is to say, an increase and a sprouting of the axon of these neurons that are going to make basically a completely aberrant connection, a glutamatergic connection on dentate granule cells, but it's also the case for the pyramidal cells. In an epileptic tissue, you have the pyramidal cells, basically the axon of the pyramidal cells sprout, make many connection and surnumeral connection on neighbors pyramidal cells. So suggesting that you have also an increase of excitatory connection. The next one. So we went and record from the pyramidal cells just to see what was mainly the functional consequences of this reorganization. Cell loss of subpopulation of GABAergic neurons, hyperexcitability of GABAergic neurons, sprouting of glutamatergic neurons. So what is mainly the functional consequences on these pyramidal cells? We show, basically, to make a long story short, we show that there is an increase of inhibition on the distal dendrite of these pyramidal cells. Here it's the sign of the patch pipette. And we show that at the level of the cell body of these pyramidal cells, you have an increase of excitation and an increase of inhibition. But basically, what we saw that at the latent period, when the animal do not display yet spontaneous seizures, you have an increase of excitability already present. And at the chronic stage, you see this increase of excitability, but it's not significantly different from what we can record from those cells during the latent period, when the animal do not display yet spontaneous seizures. So what it means that if hyperexcitability of these pyramidal cells of the hippocampus are necessary, they are clearly not sufficient for the expression of spontaneous seizures. So this, well, we can pass that. So this led us to wonder what could be other networks that could participate to the emergence of these spontaneous seizures. And the clinician has been telling us for many years that, of course, we need these seizures are characterized by hyperactivity of neuronal population, but the occurrence of seizures require also synchronization of this neuronal activity across this limbic cortex. So we, Claudio, sorry, we went and basically looked for subcortical structure that could be involved in this synchronization of the limbic system. And the supramammillary nucleus was a good candidate because it's a nucleus that it's located in the above the mammillary body, and it has been shown for many years that these neurons innervate all limbic cortex, including the entorhinal, hippocampal, amygdala, and these neurons innervate also the dentate gyrus, that it's the main entrance of the information in the hippocampus. So it has been shown also that this nucleus regulate hippocampal theta rhythm, activate dentate granule cells specifically during REM sleep. It's what Pierre has been showing you, and control some cognitive function we will talk about. And we know that all these functions are altered in mesial temporal lobe epilepsy. So it was a good candidate to look with an hypothesis that it could be an essential component of the epileptogenic zone involved in the limbic cortex synchronization and emergence of spontaneous seizures, perhaps according to emotional and or vigilant state. So we start to look at this network. But when we start to look at this network, mainly it was known that the neurons from this lateral part of this nucleus was innervating the dorsal dentate gyrus and lateral dentate gyrus with a decreasing gradient. And the neurons from this middle part was innervating CA2 and the ventral dentate gyrus, involved in different subnetworks, therefore. But the neurotransmitter used by this projection was not known. So this is the first thing that excitatory GABAergic projection was at this time a huge debate. We show that, I will show you mainly the data, and we were really surprised to discover and describe for the first time some projection that has some unique properties. They are using GABA and glutamate, two fast neurotransmitters, and they have this GABAergic and glutamatergic neurotransmitter phenotype. these projections were mainly glutamatergic. I'm going mainly to describe this network between the sum lateral and the dentate gyrus. So if you inject, so how we discover this dual and kind of unique and surprising properties of this projection. So what we did first is we inject a retrograde tracer in the dentate gyrus that is going to label specifically these neurons in the sum lateral, and then we combine, as you can see at IOMAG, and we combine that with different technical approach in situ hybridization immunohistochemistry to demonstrate that at least all those neurons that project to the dentate gyrus had a GABAergic phenotype. They contain, for example, the messenger RNA for one of the synthesizing enzymes of GABA. And if we inject an anterograde tracer in the sum lateral and look at the profile of this bouton reaching the dentate gyrus, you see the bouton at IOMAG, when we combine that with immunohistochemistry, we show that all those boutons contain these GABAergic markers. But surprisingly, they were showing also markers of glutamatergic network that Pierre talked about, called the vesicular glutamate transporter, that it's a specific marker of glutamatergic neurons of the diencephalon. So not only all those boutons contain markers of GABA, but they contain also markers of the glutamatergic neurotransmission. And surprisingly, these huge boutons are making symmetric synapses that are supposed to be inhibitory, as well as the same bouton is making asymmetric synapses on the target neurons. Okay, so asymmetric synapses are supposed to be excitatory. So this anatomical data suggests that these neurons use GABA and glutamate both for neurotransmission. I'm going to go fast like that. We look if it was also properties in that this network displays the same properties in mice, while in mice, because this is, as you know, very useful models to then use transgenic mice to modulate the network. I will show you the data later. So the mice basically display the same properties. The neurons of the sum lateral neurons display markers of the GABAergic and glutamatergic neurotransmission phenotype, and that's they contain both messenger RNA. And this is in pink. I don't know if you see. And we see only few blue neurons, the glutamatergic neurons only, or GABA neurons in red. Okay, and the bouton of these neurons innervate the dentate gyrus contain markers of the glutamatergic and VIII. But it's not only restrained to rodents. We went and looked if in primate and in macaque and in human, we saw the same properties. If this network displays the same properties, GABA and glutamatergic properties, and indeed, yes, here you have the supramammillary nucleus. These neurons here with this double contain both markers for GABA and glutamatergic neurotransmission, and their bouton innervating the dentate granule cells contain both markers too. So, it's these unique properties. So it's present not only in rodents, but it's also properties that of this network in general, of this network, and present in human too. So we went further, since the anatomy was showing, suggesting that these neurons could be excitatory and inhibitory. We went further and tried to modulate this network and see on the target cells the basically electrophysiological response. So for that, we have been using an optogenetic approach by introducing in this projection an excitatory opsin. We use for this purpose transgenic mice, Cree mice, where Cree was under the expression of Cree was under the expression of VIII. And so we basically transduce these neurons of the sum lateral and look at the terminals. And we have been with light and on hippocampal slices of these animals, stimulating this projection and looking the electrophysiological response on target granule cells. And we show basically that when you stimulate this network, you induce simultaneously a glutamatergic and GABAergic response. Glutamatergic AMPA and MDA response, and GABAergic GABA-A response that it's stronger, but the two are basically so this shows you that you have indeed a co-release of GABA and GLU on the target granule cells, and that this projection use both GABA and glutamate at the same time. For what? So we believe, and it has been shown actually more recently, that these properties actually are essential to potentiate the entrance of the information coming from the entorhinal cortex through glutamate and the depolarizing response, so potentiating the entrance of the information and synchronizing through the inhibition, can discuss of that, the entrance, the information within the dentate granule cells layer. So allowed, I'm sorry, the dentate granule cells to discharge really with a very high temporal precision and profile. So, and so what is the role of this dentate gyrus pathway? I will go very quickly on that, but with Pierre we have been conducting an experiment where we have been basically stimulating in this transgenic mice this network and by activating or inactivating this pathway and looking the behavior and associate oscillatory activity during the different vigilance state, okay? Slow wave sleep, REM sleep. And basically what we have been showing is that when you stimulate this network, you are going to increase the theta power and frequency specifically during REM sleep, not when the animal is awake. So, and what you induce has revealed by C4 immunohistochemistry that when you stimulate this network, you basically are going to activate the dentate granule cells as revealed by the C4 staining. So what I have been showing you that this pathway display unique GABA-glutamatergic and GABAergic co-transmission on dentate granule cells that can allow this cell to discharge with a high temporal precision. And it increased theta power frequency during REM sleep allows the discharge and showing that this lead to the discharge of granule cells. And we, so how this network behave in the, I'm sorry, I just want to show you that there is 2 papers that recently have been showing that this network actually is essential to transmit a novelty signal to the dorsal dentate gyrus and engaging the granule cells during encoding of contextual memory, and its consolidation. It's also instrumental for its consolidation, the consolidation of this memory during REM sleep. So what are now this property of the some dentate gyrus pathway in temporal lobe epilepsy? Actually, we saw a huge stretching of these fibers coming from those neurons in the supramammillary nucleus, in this hypothalamic region. These neurons are going to send, of course, to innervate the dentate gyrus, but in epileptic animals, what we see is that the bouton of these neurons are going to invade the entire inner molecular layer as compared to control. Here it's with an immunohistochemical markers for one the vesicular GABA transporter. And you see that at the chronic stage, when the animals are epileptic, you see these huge numbers of terminals that invade completely this inner molecular layer. You see, here you see the fibers with the anterograde tracer, and these new connections are going to at least this bouton are going to form new connection on granule cells. And this, we check that actually in the epileptic animals, this pathway has the same GABAergic and glutamatergic phenotypes that in control animals. It's the case. This is the case. This is epileptic animals with these fibers invading all the inner molecular layer. And in these epileptic animals, they contain these fibers coming from these neurons of the sum contain glutamatergic and GABAergic markers. So we went further and tried to understand what was the functional consequences of this sprouting of these fibers between the supramammillary nucleus and the dentate gyrus. So for that, we basically induce these models in these transgenic mice. Okay, implant these mice with optic fibers and with LFP electrode, and basically record the seizure in line for many days in these animals, and this system allowed you to detect automatically the seizures and to stimulate or inactivate this network through basically an optic stimulation as soon as the system detects the seizures. And we do that in 50% of the seizures that the system detects in the animals, and we do not stimulate or trigger the laser in 50% of the other seizures that the system detects in order to have internal control. So what we are seeing, so this is to show you that in this animal, the seizures occur basically in cluster. You have few days where you can record at different time of the day the seizures, and we have been basically recording from these animals for more than 90 days, 3 months almost, and you see that those seizures occurred by cluster, okay? And we have long period without seizures, and then we start again to see these spontaneous seizures. And what we observe also that these seizures occur mainly around 5 to 6 p.m., just before we turn off the light, and so the seizures occur mainly at the end of the inactive period in these rodents, in these mice, and the beginning of the active period. These animals are diurn, of course. So we have the occurrence of seizures follow a multidian that we don't know is regulated by which network and a circadian rhythm. We haven't been seeing when we modulate this network, this sun-dentate gyrus pathway, any difference according to the electrographic profile of the spontaneous seizures. But we haven't been also seeing any difference regarding the duration of the seizures when we modulate this pathway. If we stimulate this pathway or inactivate this pathway, we don't see any difference between the seizures and the modulation of the pathway or the seizures that were not, where we haven't been modulating the pathway. So there is no actually obvious effect, modulation of the duration of these seizures by this pathway. However, what we are clearly see is that when we activate this pathway for some time, so after several days of stimulation, what we start to see is an increase of the numbers of seizures that we can record per day. When we inactivate this pathway, we see a decrease of seizures that can be recorded, we record, and this is a control. So basically, and another point that we have been observing in this animal, that when you chronically activate this pathway, where we are seeing in these animals is a collapse of the GABAergic markers in those boutons. So perhaps this increase of frequency of number of seizures when you activate this pathway basically could result from this collapse of GABA within this bouton. But so to conclude this aspect, what we basically have been seeing that the sustained activation of this pathway clearly worsens the epilepsy by increasing the occurrence of seizures. And this could be related to a collapse of GABAergic transmission. This is something that we have to test now. Thank you. This is the people that have been contributing or doing mainly the work. And I thank also all my collaborators, including Pierre, and our new collaboration now with Claudio in order to go deeper in these properties of this network for controlling seizures. Thank you.
Thanks, Monique, for very interesting talk. I open for questions from the audience. Anyone? I do have one question. You showed that the lateral part of supramammillary nucleus projects to the dentate gyrus, right? And in your scheme, it connects only to granular cells. But Do you have any evidence that connects also to interneurons that should be there and they are not there anymore? I mean, how is the excitatory and inhibitory synapses distributed among granular cells and interneurons in the dentate gyrus?
Thank you for this question. Yes, Claudio, I have been showing you that this pathway innervate the granule cells, but not only the granule cells. This pathway innervate also a specific subpopulation of GABAergic neurons that are parvalbumin basket cells. So this subpopulation of GABAergic neurons that control perisomatic inhibition, and that play a fundamental role in the synchronization of the activity of the granule cells. So, but this pathway do not innervate other type of interneurons, including the one that basically die, and not the ones that are surviving. So. Only parvalbumin interneurons.
And if you stimulate that pathway in non-epileptic animals, do you observe any change in excitability or not? So if you have a control animal and you stimulate it for a long time, do you see any change in excitability over time, or don't you see any difference at all?
This is something that we like to do now. It's to see if we chronically stimulate this network, are we going to be able to basically generate spontaneous seizures? It's something that we are basically now starting to look.
Great. I have also another question, just a very technical one. The stimulation that you apply, how long it lasts, and I saw from the scheme that it starts maybe 5 seconds after the beginning of the seizure. So, and it seems from the diagram that it lasts for a couple of seconds only. And then you look for the rest of the seizure itself. But usually you know how long it lasts, the stimulation, so it ends before the seizure ends, or it's spent throughout the seizure activity?
It's spent throughout the seizure activity.
Okay, I see. Okay, yeah. Thank you. Anyone else?
Hello. Yeah, I was curious, did anyone check whether this pathway from the supramammillary differentially innervates adult-born neurons in the dentate gyrus? Is there any story there?
Yes, actually we did this experiment, and this pathway innervate newly born granule cells, but actually when they are just generated, but as soon as they start to basically mature and be included in the network, in the granule cells layer, this pathway innervate those newly born neurons. So. Yeah. So, yeah, we talk about, yeah, and it would, at least it's an hypothesis, but could this network actually, because when you stimulate this network, we clearly see, and I think that Pierre has been showing some of the picture, and mine too, that when you stimulate this network, despite the fact that this network is innervating whole granule cells, so seems to have a huge, innervation of the granule cell layer in the intermolecular layer, we only see few activated neurons with CFOS dispersed in the granule cells. And this is a question, could are we just activating the population of newly incorporated granule cells in the network that could then play a role in acquisition of new memories, basically? But this needs to be investigated. Yeah, but when as I was telling you, it's not, we see, but when you look at the innervation of this pathway, it's mainly in the supragranular layer. And we see the fibers disperse in the granule cell layer. But this could be correspond to newly born neurons that start to maturate and be included in the network. Yeah. And actually we see this connection between this pathway and these newly born neurons when after perhaps 2 weeks, when these newly born neurons display already an apical dendrites, start to displace beginning of a mature, at least mature apical dendrites.
More questions? Well, oh, it is working. Maybe you put down. Can you hear me? Yeah? No? So I will speak loud. Okay, now it's better. Thank you. Monique, I have a provocative question for you. Okay. And my provocative question is, considering the recent paper of decoupling in the cortex during REM sleep, meaning that you have a strong activity of the dendrites together with inhibition of the soma, my question is, do you think that the supramammillary projection to the granular cells could do exactly that during paradoxical sleep? Because you showed that there is an excitation of the inner molecular layer, at least the excitatory synapses in the inner molecular layer, together with inhibition of the soma. So my question is, do you believe a possibility that the supramammillary projection to the dentate gyrus is producing decoupling only during paradoxical sleep? Why? Because when you show your data about the frequency of spontaneous seizures during the day, in the example that I've been analyzing, the one you show, it's clearly concentrated in the last hour of the light period. That is when the pressure for REM sleep increases significantly before the lights off. So it seems to me, and I would love to put some hands in this data, because it seems to me that this increase of spontaneous seizure frequency is correlated with an increase of REM sleep that triggers activity of the supramammillary nucleus to the dentate gyrus, that this projection is producing decoupling of granular cells between the information coming from the cortex during REM sleep, that in epileptic animals cannot compensate that, and that's why when the animal wakes up, it leads to a seizure. So just a provocative, could the sum be the decoupling mechanism of granular cell?
It's not provocative, it's a beautiful idea that we can think, the three of us, how we will be able to actually kind of dissect this question and try to see, but it's with the track mice, and yes, but it's a beautiful idea, yes, because this, the animals, epileptic animals could perhaps, due to this reorganization of this network, could not compensate for this decoupling, and then it will trigger the seizures. Yeah, that's a
something for
idea.
the weekend.
It's not provocative.
Some
I
for
love
the weekend.
the idea. We need now to work on it.
No, I I like your idea, Claudio. I don't know if it's occurring in the dentate, what they found in the prefrontal cortex, right? That, and by the way, they found that parvalbumin neurons, I don't know if parvalbumin interneurons, right, are inhibiting the soma.
Yes.
And then you have another set of interneurons, VIII interneurons, inhibiting somatostatin neurons, so disinhibiting the dendrites. So I don't see, of course there is no sum here, there is the claustrum. But what is interesting with the claustrum, and it's also activated during REM, is that the claustrum is also projecting to interneurons. So you see there is something not completely similar, because claustrum neurons are not GABA glutamate, but you see that this kind of organization. So, of course, we need to work, and it's difficult to do calcium imaging of dendrites in the dentate, right?
And in addition, remember that in these epileptic animals, the specific population that degenerate are a population that innervates specifically the distal dendrites of granular cells or pyramidal cells. So basically, in this network, you do not have the same potency to control and modulate the entrance of the information from the entorhinal cortex, because you have basically the somatostatin, the subpopulation of somatostatin neurons that innervate the distal dendrite and control the modulation of the entrance of the information coming from the entorhinal cortex are not there anymore. So it's...
Questions? So the last chance. So if the students want to initiate their career here, making questions to an international speaker, that's the chance you have. So give 1, 2. Broadcast live your questions. So with that, I would like to thank again Monique Esclapes for the fantastic talk. Thank you very much. And I pass the word to the organizing committee, so I don't know what's next.
Thank you, Claudio. I think next is just to thank. We're coming to the end of another house symposium, another successful house symposium. Thank you, everyone, for being here. And I'd like to thank particularly all the people from the PG Neuro, our graduate program, Emanuele, Ana Luisa, Ingrid, Lucas, well, all the speakers. The commission we have that helps with all the events we're doing, so Gabriel, José Vitor, Jaime, Grace, vou esquecer gente. Yeah, go, thank you. So that's it. Thank you so much. I'd like to invite either Emanuele or Ana Luisa for our final words.
So we want to thank everybody for the participation. Especially, we have a list of people that is in the background of the event, especially Emanuele, and she's like coordinating the whole students, and she's like have this dream of making like a really good event, and she's like really commitment with that. So I think that all the students, we all embark together with her idea. So we want to thank all you guys, especially Gabriel, Ju, Ismael, Israel, everybody that have been so commitment with everything. Joey, Joinho, Diego's students for the show that is going to happen right now. In the same space, this 0 floor that we have been making the coffee break. So please come to our ending concert, and thank you all you guys for all the participation, the engagement. Everything was really good.
So we'll have live music, right? Acoustic.